now have the privilege and honor of introducing you to a colleague from UCSF, Dr. Anna Chodos. She is the executive director of a state-funded program called Dementia Care Aware and an associate professor of medicine in the Division of General Internal Medicine at Zuckerberg San Francisco General and in the Division of Geriatrics. Dr. Chodos.
Thank you so much. Thank you for having me this afternoon. Good afternoon. And thank you to this amazing conference. I have to say it's incredibly well organized and executed. So thank you to all the organizers. And really want to extend my gratitude to the panel. It looks like they all wisely left to take a break. But if they happen to see this recording, I do want to say thank you because I think that was really moving, incredibly generous of them to share their experiences. My talk is going to be so much more dry, but I hope you enjoy it and learn something. It definitely connects to all the things we've been talking about today. So I'm going to try to connect to all the amazing initiatives we heard about, like the BOLD initiative and the work with the ACCT-AD toolkit and the earlier panelists. As Freddie mentioned, I work in San Francisco. I work in San Francisco General in our clinics there. And I used to do primary care. Only of late have I switched to doing embedded geriatrics in a primary care clinic. And we have a interprofessional dementia clinic too. So that's kind of where I'm coming from, in addition to being very fortunate to work on this initiative with many, many people in the room here as well, which is also very nice. My objectives are going to be to talk about the overall broad goals of the program and the key components of the bigger program. That actually will be pretty brief. And then I want to talk about how we've approached this idea of early screening. And I'm going to kind of stop there. I know we've all talked about and thought about the bigger picture, what happens immediately after you do that initial assessment. That is, of course, extremely important. We just heard how important that is, and we've been hearing about that all day. I do think some of the other speakers did a much more comprehensive job than that, than I'm about to do. But I'm going to really focus. I want you to get a real sense of how we're promoting a way that you could assess dementia in primary care, and hopefully how we could do it as a team, or how different members of the primary care team, including perhaps those who are in social services outside of the specific clinic setting, could help with this. And I really look forward to hearing your ideas as well after this presentation. The big overview, though, is we are can you see my little cursor here? We are a short-lived program as it stands right now, so we're working very hard and very quickly to help bring what resources we have in this approach to primary care. We are funded by Medi-Cal, and so our main target really are Medi-Cal patients. Those could be dual eligible, but this was actually born of a new law, SB 48, that opened up this benefit to people who don't have Medicare, because what happened was there's no real specific mechanism for Medi-Cal only older adults who don't also have Medicare to get a cognitive health assessment and have that adequately reimbursed. However, we all know that if we're working in primary care, we're seeing patients. We're not seeing Medi-Cal only versus Medi-Cal, dual eligible or whatever it is. That's not really how we're thinking. So the approach doesn't think that way either. I just want to point that out. But we're so fortunate that lawmakers were thinking this way and wanted to open up more access to assessment for everybody. So we're doing trainings. We're creating a ton of education and resources and trying to make that highly usable, highly accessible. And then we also have a whole arm of our effort that's there to support primary care and do essentially practice coaching around how you're going to do the assessment, how you're going to do the next steps. And if I were to say what our real goal is, it's really that at the end of this time, at the end of our program, that primary care feels more empowered to tackle this, that they feel it's doable, that they feel they can begin to wrap their arms around it. And of course, we want early detection so we can connect people like Greg and his wife to earlier care, earlier resources. Or I should say resources earlier. We do have many different activities on top of the training. So really the foundation is the cognitive health assessment, which is what I'm going to spend some time talking about, giving you a sense of what those components are. And then we're creating a bunch of other trainings to really address the needs of Medi-Cal recipients specifically. So things like, how am I going to do the assessment if I'm not language concordant with my patient? What tools would I use? What would I do if the functional assessments maybe need to be modified because the person's experiencing homelessness or they're in jail at the moment? things like how to modify for communication barriers outside of language, so things like hearing or other invisible disabilities. And we are doing this through formed modules that will be online and available anytime. We're trying to get as much CME and continuing education credits for that as well. But we're also doing monthly webinars, and we're doing ECHO series, and we're tapping into a lot of the ECHO series that are already happening around the state. We're going to be starting a podcast to just break it down more quickly so you can listen into the cars that it's very possible you're driving around here in LA. And just trying to reach people with as many modalities as possible. We're doing outreach, so we have a whole outreach arm, including with marketing and actual cold call phone calls with outreach team members. And then this practice support arm, which we're getting up and running now, things like our website that could be on demand, a warm line, so can you call a clinician to talk over a case sort of as an additional ear or just talk through the cognitive health assessment. We want to create a nice portal for people to really know what resources there are in different counties and access them. Sounds like, Joseph, I need to get a download of your resources. And then the ECHO conferences, and then our most sort of Cadillac offering, if you will, are practice coaches. So people who could spend many hours over the course of months with a practice figuring out how they're going to implement the cognitive health assessment and everything that comes after and create workflows that are going to be sustainable for that clinic. And finally, we do have an evaluation component really to make sure we're meeting the needs of older Californians and particularly older Medi-Cal beneficiaries. So I'm sure that's a very broad overview, and I would be really, really happy for any engagement afterwards on any of these, any aspects of the program to help you understand it better. But I'm going to transition now to just really focus on what the foundation of this program kind of is, which is the cognitive health assessment. How do we begin to open that door? I think we did see that there's a variety of ways that people could come to you, and you could sort of start walking down this road with them. Do you have cognitive impairment with preserved function? Do you have dementia? Do you now have functional impairment or disability, as Sue was rightly pointing out earlier? But we know a lot of people don't self-present, or they don't really bring it up. So this is designed as an annual assessment, something that would help you as a provider, as a team, sort people who are more likely to have something going on versus people who are less likely. And we've emphasized that the things you really need to be doing that quick check on would be cognition, but also function. And then actually what we've put right up front in this really quick several minutes assessment is to assess their support system. Obviously, that's not going to be the lengthy, super thorough advanced care planning discussion that you'll want to have at some point, but it's just to start to lay the foundation that this is absolutely top of the list of things we need to be assessing, documenting, and starting to work with people on, is understanding who their support system is. And I will say, honestly, for much of my practice, many people don't have that support person, but that's also super important to know. And so we really describe this as the start of a diagnostic assessment. This is something that's doable in the context of maybe a larger visit, but kind of tells you whether or not, now that you've opened that door, if you're going to have to walk through it and how you're going to sort of plan that out, chunk that out in future visits. And we heard that from the panel, the primary care panel earlier. That's really how they have to do it. They have to sort of break it down into pieces. I was very touched by Greg's comment, however, that that's not the most patient and caregiver-centric thing that we could be doing. But I think for the realities of a lot of us in clinic, it's definitely feels more manageable. And then we added in, because we really felt that this was important as well, that not only do we have these three foundational pieces, cognition, function, caregiver, but we want to start actually already getting a brain health plan started. This is the stuff you can do already. This is stuff that helps everyone, but especially if there's some symptoms, you want to get this going right away. Like, why would you wait? These are things that are absolutely helpful to everyone. So really briefly, if you go to our website, dementiacareaware.org, you'll find our training. It is currently the only one available, and you can register for it. And this really enthusiastic doctor is there to welcome you to our training. And then you click through and you're inside our training course, and it has sort of 3 boxes, and you just have to click through the introductory information and briefly take a look at it. But the real module is the one in the middle, and we have it timed at 1 hour and 30 minutes. We are not timing you. After this talk, you're going to be able to whiz through it if you want to, and you can get CMEs and CEs for many different licensed categories. And it really helps us if you do the course evaluation as well. But basically, a lot of what I'm about to go through is going to be in this training. Actually, I might come back to this right at the end. So what is a cognitive health assessment? Actually, let me see. Oh, okay. The cognitive health assessment is essentially, we advocate 3 steps. You start with taking history. Part of the reason for this is actually how most people end up coming into a cognitive health assessment. So exactly what they were saying earlier in the primary care panel, the Staying Healthy assessment has that question. A lot of annual wellness visits that have been implemented have kind of trained practices to ask one question, like, have you noticed changes in your memory or something like that? So the history could be really, really brief. It could also be your observation that the person's having trouble. That could be sort of the piece of the history that counts for this step. The second is we're advocating, and it is in fact part of the legal requirement, that you use a tool, use an objective tool. So we've heard the term MOCA already a lot. We present some other options. In fact, we don't mention the MOCA in part because at this point you have to do a training and be signed off on it. So we recommend tools that you don't need that step. And the mini-cog, of course, is one of them. But we recommend that you assess cognition and function with a tool or a checklist or something somewhat structured. And then third step, establish and document the patient support system or healthcare agent. So those are the 3 steps. And we emphasize in the training and sort of all along, as I just mentioned, that this is sort of getting at what's been coming up all day, which is, what is the motivation to do this? And what we try to tap into is, I know we're here all very bought in, but to our colleagues who are thinking, what is really the point? That we already see how pervasive brain health is to everything else that's going on with the person. It's already there, and so it's already steering our care for everything else. So let's address it. Let's take that step. Let's kind of lean into it. And then it's already something we can address with all these great brain health support mechanisms. And so once again, we recommend kind of right away at that visit, the to-do items are, as you're sort of disclosing, I'm going to go over this again, as you're disclosing to the person about what your findings were, you talk to them about all that you can do today, like checking hearing and vision, helping them find a way to be more socially and physically active, helping them by undoing some of the things you did with the medications you prescribed, and the one thing we actually do tend to be fairly good at in primary care, which is continue to manage blood pressure and diabetes. And then the other thing we emphasize in the training is that the cognitive health assessment is another way to kind of remember how we're eventually going to get to a diagnosis, although we don't at all advocate that this brings you to the point of a diagnosis by just getting this information, of course. But that the pillars of the diagnosis are really a syndrome. This is a syndrome diagnosis that we're getting out of the DSM-5, right, the psychiatric manual, that points out that dementia is diagnosable if the person has evidence of an acquired cognitive decline, acquired functional decline, and we've ruled out other causes. So this is we just harken back and try to remind people about why these are the elements of the CHA. It's because these are the diagnostic elements, and we will get there, and we're helping you get there. Because I think another thing we're really trying to do, we can't really empower people if we don't make it feel more doable, more understandable. And dementia, I think many of us were overwhelmed by how Sandy got her diagnosis, and the fact that so often providers are just uncomfortable delivering the diagnosis, when really, in a lot of ways, I know I'm oversimplifying, but we have fairly simple criteria right in front of us, but it's just simply hard to, I know she got a specific diagnosis of Alzheimer's disease, which is sort of the next step after acknowledging there's a dementia syndrome going on. And it sounds like she was still pretty mild, which makes it even harder. But we want to be able to tie the assessment to why we're doing these components. And so we, in the training, really point out what the definition of dementia is and how it's, frankly, more achievable than we often get to. Okay, so now I'm going to go through the actual components and how you might do it. And then I'm going to go through a case example. So taking the patient history, as I mentioned, could be really, really simple. It could be, in the last 3 visits, I've noticed that they haven't made the medication change we've discussed, and that's not something that she would have done before. It may be that they're in here after 9 months because it looks like all of a sudden they're missing appointments. That might be a trigger symptom. But it could also be a really purely screening question that the person gets through the Staying Healthy assessment or another survey or another triage question. We're working with one clinic now that I know this is often very hard, but their medical assistants actually may start doing this question with older patients. But simple questions that are often used are, do you or others think that you're having trouble remembering things? And during the past few years, have you or others noticed changes in your mental abilities? These are just options, and another thing we were trying not to do, although this makes it harder, I think sometimes for implementation, is be prescriptive and say you have to do it this way. We realize clinics may have already something in place or a different approach that they want to use. And so these are really suggestions. And then the whole point is, ask these questions, get the answer, and then document if this was a positive response or what the response was and kind of who reported it. And then, as I mentioned, you can go on to the second step, which is use a tool. And you would do both, so it wouldn't just be you ask the question and then go to a tool if it's positive. It would be ask the question, could be positive, negative, and then go use a tool. Kind of do the whole thing. And so we present several options. Again, this can make it harder to implement. I fully recognize that. But we did want to give practices options because I think we're all dealing with different patient populations. We're all dealing with different skill and comfort levels in our team members and different time pressures. So we give options to actually get these tools done with an informant, with a patient, or you can mix and match. So what would you do to assess for for cognition? The mini-cog came up many times, and I know many of us are familiar with that. There's also informant surveys like the 88 or the short IQ code. There's something called the GP-cog, and has anybody seen the GP-cog? Just getting some head nods. We happen to use it a lot. It was developed in primary care in Australia, but it does come in many of the languages I think are very common for our patients. And it's a mini-cog with essentially a couple extra questions, like tell me a news item. Can I remember the questions? Instead of 3 words, it's remember a name and address, news item, clock draw, date. Thank you. It's the date. You have to remember the date. And then for the functional items, I think an ADL, IADL checklist, you could give the patient or you could ask them. And the GP-cog, the other really nice thing about it is if you decide to use that, it has both elements already baked in, and it has a functional questionnaire you give an informant. Many times I've used that with a patient as well. Although, understandably, at some point we often want informant information. So just to point out, you could do a combination of things, what kind of works for workflow, and who the patient is. Like, did they come with somebody? Did they not? I think many of you know the ADLs and IADLs. We have sort of a checklist version on our site. And the bottom line is when you're using the tools, I think we all know that at some point it's incredibly helpful to have an informant, someone who knows the person and can report about their functioning and cognitive symptoms. And if that person is available, we really recommend that you particularly check them at this stage, at the early screening stage, especially if the person themselves is negative on the screens, because then you really get additional information. If the person is, has a mini-cog that isn't normal, you're going to proceed anyway, and you're going to at some point have to get more collateral information. But at the very early screening stage, if everything's negative with the patient, we recommend kind of really trying to get some additional information from the informant with these tools. And then finally, we recommend this whole take a moment to establish and document the person's support system and or healthcare agent. And I think we all recognize that there's a lot of terms for who people are in people's lives. There's a lot of variation, a lot of caregivers who wouldn't self-identify that way. the patient wouldn't identify them that way. So we take a moment and just define that, you could be able to document that they have an informant who's someone who can give you information about their day-to-day functioning and cognitive symptoms. They could be a support person, someone who's really there day-to-day. And I think one of the panelists earlier really emphasized that you really at some point need to be talking to somebody who really knows and is there day-to-day. And then finally, a formal healthcare agent. So always, always good. We in healthcare love to know if there's a formally designated healthcare agent. And we give some questions that you could try as well. Do you have anybody who's available to speak with me and knows you well? And in a way, that also starts the question about permission. I was thinking a lot about what Greg was saying. How is this supposed to happen? How am I supposed to transfer information to you if my wife's in the room and she's in deep denial about what's going on? I don't know what your answers are. I usually start a visit acknowledging always talking to the patient, acknowledging who's in the room, asking them to introduce the person, asking how we should do the visit, because I would like to talk to them and ask them questions independently if that's okay, getting permission and not just sort of without transition, just switching to talk to that person or kind of asking them to give information without the patient being aware and bought in. Especially important also, I find, if the informant doesn't speak the same language or speaks English and the patient does not and starts talking to me in English, I find that we usually need to take a minute and really establish what's being said. In the training, and again, as you guys all know, we really emphasize again and again just how important it is to try to find and document, if we can, who the folks' support system and healthcare agents are. Just a point that if the person is Medi-Cal only, again, this really whole program developed because we do have now an opportunity to bill for this 5-minute assessment with Medi-Cal billing, a new Medi-Cal billing code if the person's Medi-Cal only. And we have a lot more information about that, and if you're working in a practice that wants to take that step, we can certainly walk you through that and walk whatever administrator is interested through that. But just to point out, there's also a lot of Medicare codes you can use that if you were doing this assessment, you could also apply. Okay, so I'm going to go into a brief example, if I can figure out how to work the PowerPoint. Okay, so Mrs. Perez, 72, and she comes to her appointment with her daughter who lives with her, Anna. And we discuss the agenda for the appointment, and I, the provider, add that I'd like to review her brain health as her provider, as part of what I do. So I ask, do you think you're having more trouble remembering things? She notes that she's forgotten to pick up her grandson more often, as she's been losing, it's mostly because, according to her, she's been losing track of time. And like all of a sudden it'll be time to pick him up and she forgot. So for the history part, I document a positive symptom and I move on to test her cognition and function. I use the GP cog and I give her the first part, and I give her daughter the informant part to fill out while I'm working with Mrs. Perez. And she scores, the way it's scored is sort of very, very normal. There's like a middle range score where you should get more information and get the functional information is how it's structured. And then another even lower score where it says you should proceed to next level evaluation. So she's in the middle, but that's a positive screen. And then her daughter returns the functional part, and it's scored up, and it's negative, saying she's functioning normally is basically what that's saying. So the GP cog would have you say, no next steps needed. I think different doctors would do different things, frankly, but this is one scenario where functionally she's sort of checked out okay. So I want to have a little bit more conversation with her about her support system, to understand who her support system is. And so I say, it's really nice that I had a chance to meet Anna today. Are there ways in which she supports you in your day-to-day life? She reports, we support each other, go grocery shopping together, and she helps me keep track of our bills. Does she help with coordinating your medical care? She comes to appointments to support me, but I make my appointments and I follow up on my own. Is there anyone else who helps you with any of these things? No, not really. Do you have a healthcare agent, meaning someone you've designated to make healthcare decisions for you if you can't speak for yourself, like, for example, this paper thing we call an advance directive? Nope, I haven't done anything like that. I haven't appointed anyone like that. May I document Anna's information in the chart today as a contact for you? Yes. So then I think we actually encourage people to disclose even the results of this first initial part, just to sort of set up that there's going to be follow-up. So one example could be, and this is, again, just to dovetail with all the other great resources out there, and I think we're going to borrow heavily from the ACCT AD website and promote, or toolkit and promote that as well, because they have scripts on things like driving and managing behavioral symptoms too. Like, these things are hard, so it's good to have a place to start. But one example of just disclosing even at this stage would be, thank you for taking the time with me today to review your brain health and involving Anna in this visit. You mentioned that you've been forgetting to pick up your grandson more often. When we did that brief test, you had some difficulty, though Anna's report of how you're doing day to day does not suggest you have serious problems with that at this time. I'll make note of this, and I have some suggestions to support your brain health now. I appreciate that you also gave me information about how you and Anna support each other, and I've made sure her contact information is in the chart. We will also follow up on this every year or whenever you notice any new symptoms. And I fully expect that people in this room have a way that this could be better, so I hope you contribute when I'm done here. And then just to document, we want to give people ways to document, and we're going to be putting some usable, what we call smart phrases for the medical record as well up on our website. But specifically for billing, you need to document what you're doing. And really the provider, the billing provider, needs to put it all in one place. And probably good practice anyway. But one thing you could do is just document in the history that the person reported a symptom of more forgetting around picking up her grandson, what the tests you did, what the scores were, how you'd interpret it, and who was an informant for the test. As I mentioned, this technically would be a negative initial screen. And then I document her support system and kind of what this formal relationship is. Obviously, it's her daughter, but not her formal healthcare agent at this time. And I document that I talked about it, disclose it to the patient, and plan for more annual screening and brain health. And so once we've started on assessing with the CHA, what we really want to do is build additional resources for providers and teams to go back to these same components. Cognitive functioning, sounds silly, but functional functioning, and social support. These are really the main areas we need to assess to know how they're doing clinically, and then of course the support system is how we're going to be able to support that person and know what and where and how we're going to mobilize community resources. And then with time, particularly as a clinician, once I've done the medical workup, the labs and imaging, if that's what's needed, and make sure I'm thorough on that end, I move to a place where I keep these pillars in mind, and I keep cognitive decline, functional decline, and support system as my pillars, both of my care planning, my assessments, kind of everything I'm doing with that person. And then just to point out, it is important to keep reassessing, because we know, and we heard some remarkable stories of effective treatments from our panel, but for many people, we expect them to progress, and so going back and reassessing these things is going to be really key. So I'll briefly say, we really want anyone and everyone to connect with us. We have a lot of local partners, which I'm going to highlight. Oh, I'm so sorry. I did that thing you're not supposed to do where I added a slide after I had submitted the slides. But I just wanted to acknowledge the very people in the room or the hallway are robust and amazing partners who are teaching us everything we need to know in the DCA team. But Alzheimer's LA, which we heard been of huge support to the people on the panel, Greg and Dave and Sandy. Rancho, USC, Rancho Los Amigos, UCLA, Harbor, and as well as UCLA has an Alzheimer's and dementia care program, which is able to do a lot of the coaching. Alzheimer's Association, Alzheimer's OC. So we are so fortunate to have these partners. They are really geared up and ready to support providers, patients, caregivers. So we want to help make those connections, although here, I know this conference is already doing that. So I'm so grateful for that. I just want to point out, so what we have right now is training and continuing education opportunities. But as we're planning how to roll out our practice support activities, we want to hear from people. Because already just today, heard so many wonderful ideas and just practical barriers that we need to be thinking about as we create resources like webinars and echo series, practice coaching, and more online resources for folks. And ideas for trainings as well. I know I mentioned a few content areas we're trying to really build out. Working with all the populations we're so fortunate to work with. But if you have ideas, we'd love to hear it too. So we try to keep our emails simple, dca@ucsf.edu. So please, I really look forward to hearing from you. Thank you.